Good afternoon, everyone. We'll start the seminar series with some updates. Maitali, here you go.
Thanks. Hello, everybody. So a couple of announcements. First off, the Graduate Student Association is giving out 2 more travel awards, this time to the American College of Sports Medicine. So if you are planning on going to that conference, be on the lookout for emails pertaining to that. Secondly, this news is a bit dated, but Gavin, who also just had a birthday, received the American Heart Association's pre-doctoral fellowship. So, and then Neil just received the APS Neural Control and Autonomic Regulation NCAR Research Recognition Award for his abstract submitted to the APS Summit. And this work is coming out of his ongoing collaboration with Dr. Lindbergh and her lab. So congrats.
Hi, note. Good afternoon, everyone. My name is Jaume Padilla. I know most of you. Professor in nutrition and exercise physiology, and today it's my pleasure to introduce James Smith, who's a graduate student in our program, and he's co-mentored by Dr. Camila Manrique and myself. James came to Mizzou from West Virginia University, where he master's degree in exercise physiology, and prior to that, he obtained his bachelor's of science in exercise science from Kent State University in Ohio. Since he arrived here at Mizzou in 2018, James has been a player in all our human studies and clinical trials, and he's mastered very critical techniques, including insulin implants, Doppler ultrasonography to measure endothelial function and blood flow, contrast enhanced ultrasound to assess skeletal muscle perfusion. He has been productive and has contributed to a total of 6 published manuscripts in which he is co-author, and one of them his first author. And today he's going to summarize some of the work that he has led and some of the work that he has contributed to, as well as some of the ongoing studies that he has. And with that, please join me in thanking James for giving this presentation.
How was that volume? Perfect. All right. Thank you for the introduction, Dr. Padilla. And yes, my name is James Smith. I'm a PhD candidate in the Department of Nutrition and Exercise Physiology. And it's my pleasure to share some of the work that I've been working on for the past almost 5 years now. And so the title of this talk today is Sex-Related Differences in Vascular Responses to Lifestyle Changes in Health and Type 2 Diabetes. To cover a general outline of today's talk, I'm going to be talking about some of the general background to understand the presentation today. And then I'll go into some of the sex-related vascular differences that we see in health, followed by the sex-related vascular differences we see in our type 2 diabetic patients, followed by some of the current directions that the lab is taking, and then I will finish off with some conclusions and acknowledgments. So this paper was published in the New England Journal of Medicine in 2019, and it stated that by 2030, nearly half of Americans will have obesity. And so if you look at this legend to the far left, particularly the dark black or the dark red and the black, that brings up all of the states besides basically Colorado, which Colorado will be estimated by 2030 that about 35% of their state population will be defined as obese. If you see on here, there's a lot of black. I believe I counted 29 of the 50 states. Their state population will be classified that about 50 to 60% of their population will have obesity by 2030. So obesity has been an epidemic for several decades now, and it's going to continue to get worse, particularly in the United States. So our lab is really focused on trying to find therapeutic modalities to address the complications that diabetes and obesity present, along with some of the cardiovascular disease burdens that occur with that. So we know that there's an inverse relationship between cardiovascular risk and physical activity. So if you look at the y-axis here, looking at cardiovascular risk from low to high, And then on our x-axis, physical activity volume ranging from none to high. We know that individuals who are physically active on a weekly basis and consistent basis, that their risk for cardiovascular mortality or disease is quite low. But on the opposite end, an individual that they have very little or no physical activity, their cardiovascular risk is very high. And one of the things that contributes to this increased risk of cardiovascular mortality and diseases is endothelial dysfunction. So endothelial dysfunction precedes structural disorders that ultimately results in cardiovascular disease. So a healthy endothelium or a blood vessel dilates and constricts to stimuli that we face day to day. However, in the setting of cardiovascular risk factors, so this can be things like lack of physical activity, smoking, high blood pressure, aging, just overall general things like that, that the vasculature starts to become stiff, okay, and it starts to become dysfunctional. So if we look at the far left here in this image, so at first, really from a patient's perspective, they're not really going to notice too much that's going on, right? That really how we test for endothelial dysfunction, and one of the ways that we do in our lab is a non-invasive in vivo assessment of flow-mediated dilation, or FMD. And this is again, non-invasive test that can determine one's endothelial functioning. And so assessed via this test, in the early stages of endothelial dysfunction, a patient would have an inability of the blood vessels to dilate appropriately, and that would be assessed by FMD. If left untreated, over time, eventually the vasculature starts to become stiffer, so the blood vessels become a little bit progressively more dysfunctional. And it's in these early stages that we really try to promote lifestyle modifications before things progress and get more severe. So some lifestyle modifications such as, what does the diet look like? Can we improve the diet? Are they eating too much? Is it too much fat, too much salt, things like that? And then also, what are their activity levels? Are they participating in physical activity? Can we encourage them to begin to participate in a physical activity program? Unfortunately, in America, only about 1 in 4 individuals, adults, participate and meet the physical activity weekly requirements. And so for a lot of people, these lifestyle modifications, they just don't come to fruition. And what can happen over time is, when left unchecked, eventually plaque buildup starts to accumulate in the blood vessels. And so at this point, right, we're looking about in the middle of the graph here. So we start to get some plaque accumulation. And what this can lead to clinically is this narrows the range of blood, narrows the lumen. And so it's harder for blood flow to travel through. And this may increase their blood pressure. And it can also have some issues with cholesterol management. And if left unchecked, this atherosclerosis, or this plaque buildup, continues to accumulate. And the next step of treatment would be hopefully, right, we can still try to encourage and get them to adopt a lifestyle modification. But in the event that that's unsuccessful, now this is where medications start to come at play. And we do both of these things, lifestyle modifications and medications, so that hopefully we don't have to, patients don't have to undergo expensive and invasive treatments, right? So when plaque buildup and atherosclerosis starts to accumulate severely, that's when we start to see clinical symptoms and events such as abnormal ECG rhythms, or potentially a heart attack or a stroke. Okay. As a reminder for some blood vessel anatomy, so there's 3 layers to our blood vessels. On the innermost layer, we have our tunica intima, and this is where the endothelium is present. So the endothelium lines the innermost layer of our blood vessels, and this is where the endothelial cells are present. And this is ultimately where nitric oxide ends up being created. It diffuses out of the endothelium and onto our next middle layer, of tunica media. And this is where the smooth muscle cells are present. And it's these smooth muscle cells that are mostly responsible for dilation and constriction to various stimuli throughout our day-to-day lives. And then lastly, our outermost layer, tunica adventitia. This is more to give structure and support to the blood vessel, and this is made up of mostly some collagen fibers. One of the things that we're interested in our lab is investigating shear stress, and shear stress is the tangential force of blood that's exerted, blood velocity that's exerted on the endothelial cells located in the endothelium. And so this would be things like if you were to start exercising or go up a flight of stairs, you would get an increase in blood flow, thus shear stress. And what this can ultimately cause is the creation of endothelial nitric oxide synthase within our endothelium. Okay. So endothelial nitric oxide synthase in conjunction with L-arginine, a naturally occurring amino acid in the body, ultimately end up producing nitric oxide. And nitric oxide is a potent vasodilator that diffuses out of the endothelium into the smooth muscle that gives us vasodilation. So vasodilation is good. It's very cardiovascular protective. And this really allows us to help manage things like high blood pressure and plaque buildup. One of the ways that we can test and examine shear stress is using a non-invasive method known as flow-mediated dilation. So this is an in vivo measure to assess vascular function, okay? So how this works is this is a 10-minute test that essentially with the ultrasound probe, we're able to look at not only the artery of whatever location we're looking at. So in these examples that are common to our lab, we look at the brachial artery as an upper extremity vessel, and then we look at a popliteal artery as a lower extremity vessel. And what we can do with this is, so a 10-minute test to determine basically one's ability to vasodilate to a non-invasive test. And so how this works specifically is there's a blood pressure cuff. So in the example of upper extremity, the brachial artery, a blood pressure cuff goes on the forearm, and we have our ultrasound placed over the brachial artery in the upper arm. For the, again, there's a 10-minute test. For the first 2 minutes, it's just baseline reporting. We're examining the baseline artery diameter, and we're also examining the baseline blood flow or blood velocity. After that 2-minute time period, we then inflate a cuff that causes occlusion, blood flow occlusion. And what that feels like for the patient is it kind of feels like if your foot's ever gone to sleep, you start to feel some numb tingliness. That's what that feels like from the patient's perspective. So it doesn't really hurt. So there's a 5-minute inclusion, and what's happening there is basically, again, we're occluding blood flow, metabolites start to build up in the vasculature. And after 5 minutes, at minute 7, we release this cuff. And when we release this cuff, what happens is those vessels downstream of where we had this cuff, they open, and that causes pressure changes that now blood flow comes surging and rushing back down that we can measure upstream on the brachial artery to look at the reactive hyperemia or this increase in shear stress, okay? And our lab has shown evidence that this increase in shear stress is ultimately what leads to one of the factors that leads to vasodilation, okay? And so what we have on to the far right is an example image of when we examine these ultrasound videos, we have a special software that detects not only the baseline artery diameter, and then also the reactive hyperemia diameter, but also the blood flow profiles and velocity that changes throughout this 10-minute test. So this test is an independent predictor of future cardiovascular risk. And it's an independent predictor of future cardiovascular risk, and this correlates very well with coronary functioning. So what I've spent about the past 4 years really looking at is sex-related vascular differences in healthy individuals. But one of the things I want to talk about before I go into sharing that data is, so it's particularly routine in our lab. We examine sex differences, both men and women, but I was surprised some years ago to find out that this has not historically been very common, okay? So I just want to reiterate and share some history of why it's important to include women in clinical trials. So during the 1970s, few women worked in medicine science, and it was believed that women's health needs were a low priority back then. Following protests in the 1980s, in 1986, the NIH encouraged women inclusion in research studies. However, this encouragement did not get adopted well. So when they recognized this, it was in 1993 that the NIH, along with Congress, mandated it by law. And essentially the rule was, if you did not include women in your clinical trials, they were not going to fund you. They were not interested in collaborating and providing support. So why were women excluded? Well, back then it was mostly thought that that men were a cleaner model. So as researchers, we're very interested in trying to keep the background as stable and consistent as possible in a research setting. And it's known that with premenopausal women with the monthly fluctuations of menstruation, that they thought that was too much work. So they mostly stuck with it, including men in their research studies. However, actually, in men, serum testosterone levels rise to 20% above mean levels at 20 hours and falls to 35% below mean levels at 7 hours. So men not only cycle, but they cycle faster and for longer than women. So from the late 1800s until the 1970s, the majority of the human data in medical texts represented Caucasian, young 18 to 22-year-old, 70-kilogram males. And this is important because there are cardiovascular differences, and the cardiovascular system shows these differences, such as in the case of a heart attack. And so if we look at this image to the far left here, while it's great that we had participants in research studies back in the day, but again, primarily they were Caucasian, young, 70-kilogram males. Here's the subset of the population we were capturing, and we're missing out on a lot of data from both men and women that do not fall in this Caucasian, young, 70-kilogram perspective. Okay. So while there were some similarities and some overlap, largely to better treat women, that research was not being done. So with that said, the first question is, at what age do sex differences in vascular health start to become apparent? So this was a study done in 2015 in about 900 some individuals, with about 60% being men and 40% being women. And this examined phloemia dilation in children and adolescents aged 6 to 18. And what they found here was that across the lifespan, there's really not too much, and so this is looking at brachial artery diameter. And across the lifespan, up until they reach about puberty, we don't see too much of a change. And then about the ages of like 13, 14, they start to notice a trend. So brachial artery size diameters start to differ between men and women. But it's really about the age of 15 to 16 years old that we really start to see significant distinctions between diameter sizes and the brachial artery between men and women. And this is indicated here on this trend line that looking at brachial artery diameter as individuals age, as children age, again, that brachial artery diameter starts to increase linearly. It's also known that phloemia dilation is inversely related to the size of the brachial artery diameter. And so we can see here with these triangles representing males and then the open circles representing females, that females have a higher phloemia dilation than males for the most part throughout this cycle. And that is due to particularly they have a smaller brachial artery size. But at the age, again, of about 16 years old, that's when the results start to become significantly predicted by age, and that females' FMD responses are dramatically higher compared to men. And we can appreciate that with the trend line as well, that as one ages for phloemia dilation, that trend line starts to go downhill. So they are inversely related. So as the artery diameter gets larger, FMD percent decreases. So from this paper, they found overall that sex-related vascular differences and responses start to have a marked difference beginning around the age of 16 years old. And so if a research team is doing sex-related differences in adolescents or children, they probably don't need to worry about any cardiovascular related sex differences until an individual is about 16 to 18 years old. So then the next question with that is, why do women have enhanced endothelial function compared to men? So there is some evidence in the literature that estrogen plays a very important and protective role in endothelial function. And so looking at this figure on the far left, so there was 3 groups. They had group 1 was premenopausal females with the mean age of their participants being about 39 years old. And this had 20 subjects in this group. Group 2 was postmenopausal females not on hormone replacement therapy with a mean age of about 58 years old. They had about 10 individuals in this group. And then the last group, group 3, postmenopausal females on hormone replacement therapy with a mean age of about 53 years old. And so what this data is looking at here, so if we look at this y-axis, this is looking at cutaneous microcirculation or skin blood flow, and that individuals that are in premenopausal females compared to postmenopausal females that are not on hormone replacement therapy, they have a higher level of endothelium dependent vasodilation and endothelium independent vasodilation compared to postmenopausal females not on hormone replacement therapy. But when you give postmenopausal females when postmenopausal females are on hormone replacement therapy, there's no significant difference as shown from this data that their cutaneous microcirculation blood flow does not change in comparison with premenopausal females. So this was an early piece of evidence that showed kind of the protective role that estrogen played in vascular function. So looking at the figure on the right, so this was looking at a macrovascular level. So this is in the brachial artery. And again, looking at flow-mediated dilation on the y-axis. And so what they did is they measured women, the sample size was about 20 individuals, and they measured them using FMD at 4 different stages within the menstrual cycle, okay? So the first so a menstrual cycle on average lasting about 28 days. The first 14 days is the follicular phase, and then the last 14 days representing the luteal phase. That what they found from this study was at each stage of the menstrual cycle, there were significant differences in their vascular function as assessed via flow-mediated dilation. And so at the time, it was kind of uncertain why and how is estrogen offering protective vascular roles, and during what phase of the menstrual cycle should you test women? So this was one kind of the earlier pieces of evidence that showed just how dramatically endothelial function can change across the menstrual cycle. And so there started to become some discussion of, so how can we standardize this and when should women be tested during their menstrual cycle? So the summary there is estrogen improves endothelial function and fluctuates throughout the menstrual cycle. And estrogen deficiency is linked to endothelial dysfunction. So the next question there is, besides sex differences, what lifestyle factors impact vascular function? And do men and women both respond differently? So this is a nice kind of summary image here that talks about some of the risk factors that go into the development of endothelial dysfunction that ultimately result in cardiovascular disease events. And so some of our classical risk factors that we think of is glucose metabolism or diabetes, their cholesterol levels, whether they smoke, have high blood pressure, or their age. And then, so this paper was published in 2003. And one of the things that they talked about back then was the novel and emerging risk factors that were different than kind of the classical risk factors that was primarily being talked about. And some of these that our lab focuses on now is physical inactivity and also obesity. So these factors right here all go into the development of endothelial dysfunction. And so in our lab, particularly, I'll be talking about some of the risk factors that we measure and modulate. So in this first study here, young women are protected against vascular insulin resistance induced by adoption of an obesogenic lifestyle. So we called this study the SOTA study because what we did is we had 36 individuals, so 18 males and 18 females, participate in this study, and that for 10 days, they drank 6 cans of soda a day, coupled with they took less than 5,000 steps per day. So to give you an idea of what that looks like, 6 cans of soda a day is a little bit more than a 2-liter a day. Okay, it's about 2.1 liters a day. To take less than 5,000 steps per day, that is very challenging. So 1 mile is about 2,000 steps. So these individuals were very inactive, very sedentary, and they were drinking lots of soda. So what we did, we brought individuals in, told them about the study, did a consent visit, and then they underwent a pre-eligibility period for 3 days in which we tracked their steps using hip-worn pedometers, and they needed to accumulate at least 10,000 steps on each of those 3 days, one day being a weekend day. That to us was evidence that they were indeed physically active enough to participate in this study. And once that occurred, we scheduled them for their pre and post test visit. And some of the measurements that occurred is a DEXA. So we did their body composition. We did some various measurements of vascular function, so pulse wave velocity, which is a non-invasive assessment of arterial stiffness. We did flow mediated dilation in the upper extremity, so the brachial artery, and the lower extremity and the popliteal artery. And then we did an insulin clamp with leg blood flow measurements, which I'll be talking about momentarily. So individuals came in for their pre-test visit, underwent all of these measurements, and then from there, they underwent the 10-day obesogenic lifestyle. So again, drinking 6 cans of high fructose containing soda a day, coupled with taking less than 5,000 steps per day. So to talk about the importance of our lab in performing insulin clamps, so we have evidence that insulin-induced vasorelaxation. So if we look here, so this is a figure that, so insulin acts on an insulin receptor located on the endothelial cell membrane. And what happens is it activates 2 opposing signaling cascades. Both occur at the same time, but depending on the health status of the individual, one predominates over the other. So in the case of young, healthy, physically active individuals, in response to insulin, they get a net production of nitric oxide, which is very beneficial, promotes vasodilation, it's very vascular protective. However, in the setting of type 2 diabetes, obesity, physical inactivity, instead of a predominating nitric oxide signaling net accumulation, they start to receive more of a vasoconstriction or a proatherogenic cascade. And so ET1 stands for endothelin 1, and this is a potent vasoconstrictor that essentially opposes nitric oxide, and this promotes a pro-inflammatory vascular environment. So we perform insulin clamps routinely in our lab. And essentially what these are is these are 3-hour tests that are the gold standard for assessing one's insulin sensitivity. And so an individual comes in fasting, we determine what their fasting blood glucose value is. And then based on some calculations, I was looking at their body weight, we infuse, in this particular study, we infuse a high priming dose of insulin for about 10 minutes. And then after that, we infuse a constant rate of insulin for the next 2 hours and 50 minutes. At the same time, while they're receiving that constant rate of insulin infusion, they're receiving a variable rate of glucose infusion. And so it's a variable rate of glucose infusion because depending on how insulin sensitive that individual is, will determine how much how much glucose they need to be infused in them or not. And insulin-mediated increases in skeletal muscle blood flow account for up as much as 35% of total insulin-stimulated skeletal muscle glucose uptake. So in the setting of obesity and type 2 diabetes, this insulin-induced vasodilation really becomes blunted and affects the vascular system negatively. So to show some of the data from the SOTA study that we did, So again, an obesogenic lifestyle we coined as these individuals were taking less than 5,000 steps per day. So you can appreciate in the pink representing females and then the blue representing males. So before they begin the 10-day lifestyle intervention and then after. And so this is looking at steps per day. Indeed, we were successful at recruiting individuals who were taking more than 10,000 steps per day. And we were successful at reducing their step count below 5,000 steps per day, with no differences observed between males and females. And when we look at their soda consumption, so there were no sex differences between the amount of sugars that they were intaking, the amount of sodium that they were intaking, or the amount of caffeine they were intaking. And lastly, I want to highlight, while there was no sex differences in the amount of calories that they were consuming on a daily basis, these individuals were drinking close to about 1,400 calories of soda every day. Okay. So this was a younger cohort. So average age for the females were 22 years old, and then for the males being 25 years old. And so if we look at these highlighted in the blue rectangles here, that we were successful at significantly increasing their body weight, both males and females, after the 10-day intervention. Their BMI significantly increased after the 10-day intervention. And then when we look at their fasted insulin values, we see that in females that they had a significant increase in their fasting insulin after the 10-day intervention, and so did males. But there was a sex difference between males and females when looking at fasting insulin values. HOMA-IR, which is an assessment of insulin resistance, and it's an estimate, we were successful at increasing that across our 10-day study. And then lastly, looking at our HDL cholesterol, so the good cholesterol in both men and women, that significantly decreased after the 10-day study. And we were also successful at increasing their plasma triglyceride values after the 10 days. When we look at their vascular responses, so looking at, so in this table, right, females here, males here. So we're looking at the popliteal artery, so in the leg, that we saw that for females that at their, before they started the 10-day study intervention compared to after, females actually improved after the 10 days. Whereas when we look at males, there was a trend for them to become more dysfunctional, okay? So that was kind of a surprise to us that females actually improved after the 10 days. And I'll cover some of the reasons why we believe that is shortly. And then lastly, looking at the brachial artery in the upper arm, we didn't see any significant differences in males and females before and after the 10-day study intervention. When we look at their vascular responses following this 10-day lifestyle adoption, so leg blood flow, so this is measured on the common superficial femoral artery. And so this is looking at its response to insulin infusion. So we're with the ultrasound looking at leg blood flow in the femoral artery while they're being infused with insulin. And what we see here is that, again, pink representing females, that there was no significant differences, whereas for blue and males, they significantly got worse after the 10 days. So their leg blood flow response to insulin infusion decreased. We notice similar trends when we look at leg vascular conductance in response to insulin infusion, that females exhibited no significant changes, whereas men became more dysfunctional. And then lastly, when we look at skeletal muscle perfusion response to insulin infusion, so this is looking at microvascular perfusion, that again, females exhibited no significant changes, whereas males became more dysfunctional. When we break down the data and just look at females, so in panel D right here, so this is looking at plasma insulin. We did a 1-hour insulin infusion. And so these data are representing every 15 minutes during that 1 hour, the open circles representing before they began the 10-day lifestyle intervention, and then the closed pink circles representing after the 10-day intervention. And we see during that 1 hour infusion for women that there were no significant differences at baseline, 30 minutes, 45 or 60 minutes. However, at time point 15 on there was a significant difference between that. When we look at their blood glucose values during the 1 hour insulin infusion, no significant differences observed. And then when we look at their glucose infusion rate, no significant differences before or after the 10-day intervention. But when we look at the data in males, so panel G here, again, plasma insulin values during the 1 hour insulin infusion, no significant differences before or after the 10 days. But when we look at their blood glucose values during the 1 hour insulin infusion, we see that they had a much higher blood glucose value after the 10-day intervention. Okay, so they had more glucose remaining in their bloodstream. And when we look at panel I here, this is looking at glucose infusion rate, so how much glucose was being infused in them during that 1 hour insulin infusion. After the 10-day intervention, males needed less glucose being infused into them during time about the last 20 minutes of this clamp. So interestingly, females during the 1 hour insulin infusion, they did not really exhibit any changes in terms of the vascular glucose metabolism here, whereas in males, they had a higher blood glucose value during the 1 hour insulin infusion, and they also required less glucose. So they were showing some vascular insulin resistance there. They were not able to clear out the glucose as well prior to starting the 10-day intervention, whereas females were able to maintain this phenotype. So one of the potential mechanisms that we investigated that might be contributing to this sexual dimorphism is plasmodropin. So dropin is a peptide that is primarily expressed in the liver, and it's known to have insulin sensitizing effects. So essentially, the more dropin one has, the better, the healthier it is. And so when we look at women here before and after the 10-day intervention, they had no changes in their plasmodropin, whereas males, their plasmodropin concentration is significantly decreased. And so having low levels of plasmodropin has been associated with the development of obesity and cardiovascular risk. And then when we looked at another potential mechanism at play, so plasma nitrite, this is a surrogate index of nitric oxide bioavailability. So essentially, the more nitric oxide an individual has, the better. That we saw with women, no changes after the 10-day intervention, whereas men had a significant decrease in their plasma nitrite that we used as a surrogate index, again, to essentially measure how much bioavailable nitric oxide that they have. So men had less nitric oxide bioavailability after they partook in this 10-day intervention. So some of the summaries from our SOTA study is a short-term obesogenic lifestyle negatively impacts glucose control in males and females. However, when we look at vascular insulin sensitivity, only men, not women, exhibited impairments. So then next, we want to examine sex-related vascular differences in type 2 diabetes. So what we did for this study is we brought in type 2 diabetics and we put them on a 6-month diet intervention that was low fructose, and we were to reduce their calories by 500 calories a day. So a 6-month study, and so we had 9 women participate in this study and then 7 men. And so they underwent some diet counseling, and what we had here at their baseline visit, so we performed kind of some of the similar measurements I explained previously. So they underwent a DEXA scan to determine their body composition. They underwent some vascular assessments of their artery structure and stiffness. We performed brachial and popliteal flow-mediated dilation. And again, we performed an insulin clamp to look at their insulin sensitivity. There were 3 visits in this study. They had a baseline visit, they returned later, 3 months later, and then they came back 6 months later for their final visit. So what we see is, so in panel A up here, blue representing type 2 diabetic men, and then the pink representing type 2 diabetic women. So this is in a sample size of about 33 individuals that we see that in both. So during again, 1 hour insulin infusion, that we are successful in type 2 diabetic patients, that we can successfully increase their plasma insulin values, and we can maintain their glucose values during this infusion. When we look at their leg blood flow response to insulin infusion, so in type 2 diabetes, we don't see the same sex differences that we see in more younger, healthy individuals. So no sex differences happening here. And then when we look at their leg vascular conductance in response to insulin infusion, again, we don't see any sex differences occurring between type 2 diabetic men and women. And so we took a subset of individuals. So again, this was about 9 postmenopausal women and 7 men. And we put them on a 6-month diet that with the goal of reducing their calorie intake by 500 calories a day. And so we were successful at reducing. So this yellow right here represents kind of the pre-diet intervention. And then they came back about 2 weeks later and they reported their dietary habits. And according to those dietary records, we were successful at reducing their caloric intake daily by roughly 500 calories. And looking at their macronutrient percentages, we kept fat the same. We significantly decreased their carb intake and their sugar intake. And then the increase that you see in protein intake, we kept protein the same. The only reason that significantly increased is just because with the calories dropping, it changed the ratio. So they kept their protein and fat the same. And so primarily this was a low carb, low sugar diet. This was effective at reducing body weight in these individuals. And so looking at before they started the study and then 6 months later, we see that individuals were able to significantly drop their body weight. This was roughly about 6.5% reduction in body weight. When we look at their HOMA-IR, so again, an assessment of insulin resistance, we were able to decrease HOMA-IR across our 6-month diet intervention. And then HbA1c, this is a blood test that looks at basically your average blood glucose values over the past 2 to 3 months. We were able to significantly reduce their HbA1c as well after our 6-month diet intervention. With that, so these were older type 2 diabetic individuals. After the 6 months, we significantly reduced their body weight, reduced their BMI, reduced their body fat percentage, and they did end up losing some muscle mass, but this is to be expected when you go on a lifestyle intervention like this, such as a low calorie diet. We significantly decreased their plasma insulin values, so their glucose metabolism improved. And then looking at some markers of kind of whole body inflammation, so white blood cell count improved. And then looking at some liver blood biomarkers, their liver function significantly improved as well after our 6-month diet intervention. And then there was no changes in any sort of blood pressure or heart rate before or after the 6-month diet intervention. So what we found in this study was that diet-induced weight loss can correct vascular insulin resistance. So looking at panel C up here, so this is looking at leg blood flow response to insulin infusion. So again, blue representing type 2 diabetic men, and then the pink representing women. That from before they started the study to 6 months later, leg blood flow response to insulin infusion, there was no significant differences observed in the men. However, women significantly improved following the 6-month diet intervention. Similar story here, leg vascular conductance responses to insulin infusion, no changes observed in the men, whereas a significant improvement was observed in the women. And then we look at microvascular perfusion. So this is a skeletal muscle microvascular perfusion in response to insulin infusion. No significant changes observed in men. However, women significantly improved after the 6-month intervention. When we look at our measurement of flow-mediated dilation, so this is in the brachial artery, that after the 6-month intervention, there was an improvement in all of our subjects. Okay. And then when we look at kind of a measurement of whole body arterial stiffness, so this is carotid femoral pulse wave velocity, there was no changes. And so what this told us is, one, that diet-induced weight loss can correct vascular insulin resistance, and that's particularly driven by women. But in terms of whole body arterial stiffness, perhaps more intensive research design and research studies are needed to correct type 2 diabetes status that has been prolonged for 5+ years, and that a 6-month diet intervention may not be sufficient enough to reverse some of these whole body vascular stiffness. And so diet-induced weight loss decreased inflammatory markers and endothelin-1. So some of the mechanisms that could potentially help to explain why did we see the improvements in our vascular measurements that we did. So in these inflammatory cytokines here, we saw that there was a significant decrease after the 6-month dietary intervention. And then plasma endothelin-1, again, this is a potent vasoconstrictor that opposes nitric oxide. So the less ET1 that you have, essentially, the better, that we were able to significantly reduce endothelin-1 after our 6-month diet intervention, which may help to explain some of the vascular improvements that we saw in this subset of individuals. So the summary from this study was female sex confers protection against obesity-induced vascular insulin resistance, and vascular insulin resistance can be improved with diet-induced weight loss in women with type 2 diabetes. So some of the current directions that the lab is taking. So we're interested in looking at the glycocalyx. So these are fine hair-like structures that are located on your endothelial cells inside of our tunica intima. And so we believe that in type 2 diabetics and those present with obesity, that they have impaired glycocalyx. And the consequences of having impaired or thin glycocalyx is individuals that undergo, let's say, for example, an exercise intervention, they don't respond how we expect them to. So some of our current directions in the lab are, so individuals that have a degraded glycocalyx, commonly found in obese type 2 diabetics, we're going to be giving them a dietary supplement. So these are supplements that are used to try and improve the glycocalyx. So DSGP, dietary supplement of glycocalyx precursors. And with the hope that these supplements will improve the glycocalyx. So you notice here this very thin versus after they take these supplements, we believe it should restore the glycocalyx, thus allowing optimal exercise-induced vascular adaptations to occur. So how we can assess the glycocalyx non-invasively in humans is using a device called the GlycoCheck. So this is a non-invasive method, again, to determine the glycocalyx in vivo. And how this works is essentially a camera goes underneath your tongue. And what this does, it looks at the blood vessels inside your tongue. So these are some representative images. And what's interesting about this is you can actually see the individual red blood cells moving throughout these small vessels inside the microcirculation. And so to give a picture representation, so in an unhealthy microcirculation, such as maybe found in a type 2 diabetic present with obesity, this is what a representative image would look like compared to a young, physically active, healthy individual. You can see just how much more microcirculation is available. And so what we find in our type 2 diabetic subjects is that glycocalyx density is reduced. And one of the things that the GlycoCheck provides for us is PBR. And PBR stands for perfused boundary region. And so essentially when red blood cells are flowing throughout our blood vessels, the glycocalyx that's present on the inside of the lumen, the amount of penetration that these red blood cells penetrate into the glycocalyx, we can calculate perfused boundary region. So the higher PBR value, the worse the glycocalyx is, the thinner or the more degradation the glycocalyx has. And so from some of our preliminary data in type 2 diabetics, we see that in age-matched controls, PBR value is significantly lower than that of type 2 diabetics, thus giving some preliminary evidence that indeed the perfusion boundary region is greater in type 2 diabetics, thus that the glycocalyx density is degraded or impaired. Additionally, we see that reduced glycocalyx density is associated with impaired flow-mediated dilation in type 2 diabetic subjects. And so if we look here, so plasma neuraminidase activity in healthy controls compared to age-matched type 2 diabetic subjects. So plasma neuraminidase is it basically degrades the glycocalyx. So in type 2 diabetics, they have higher concentrations of plasma neuraminidase that might be contributing to this degradation that we see in their glycocalyx density. Additionally, plasma sialic acid also degrades the glycocalyx, and we see that in our type 2 diabetic subjects that is significantly higher compared to our age-matched healthy controls. So again, representative image of brachial artery flow-mediated dilation. And what we see that in our individuals that have high concentrations of plasma neuraminidase and sialic acid in our type 2 diabetic subjects, that their brachial artery flow-mediated dilation percent is reduced. Okay. And so some preliminary data in a mouse model is that these dietary supplementation of glycocalyx precursors, DSGP, will improve the glycocalyx length and density. So sample size is about 4 to 7. So in these diabetic mice that are treated with either a peanut butter vehicle or some glycocalyx supplementation precursors, we see that in these mice, we are able to increase the glycocalyx length and restore the glycocalyx density. And when we look at their flow-mediated dilation as assessed in isolated mesenteric arteries, that the diabetic mice that are treated with these glycocalyx supplementation precursors, they significantly improve following this supplementation. So it is our hope that we, in type 2 diabetic subjects, they will undergo an 8-week intervention where they'll receive either placebo or these DSGP supplementations, that individuals, type 2 diabetic individuals who do have the DSGP supplementation, that they will increase their glycocalyx integrity, their insulin stimulated leg blood flow, their flow-mediated dilation, and that these supplements will also decrease their blood pressure compared to type 2 diabetics only receiving a placebo treatment. And then I would like to give some acknowledgement to my advisors, Dr. Padilla and Dr. Enrique, for having lots of patience with me. The dissertation committee also having lots of patience with me and providing lots of support, so thank you. And then these are our colleagues and collaborators here that have helped me along the way. And so I'll take any questions now. Yeah.
Quick question. I was just curious. Nice presentation, by the way. So it's a study where you created a ketogenic lifestyle and gave them like lots of soda.
Yeah.
What was their baseline? How did their baseline intake of soda? How did you decide who the aspect? They were
So they underwent like a screening that basically they were ineligible if they consumed more than 2 soda per week, 2 cans of soda per week. So primarily the people that we recruited were very physically active and they did not drink soda, high amounts of soda on a regular basis. Sugar sweetened soda, yes. I saw you next. That study, great presentation, and you measure estrogen levels in the females before and after, see if there's an effect of protection that you talked before. Which study? The first study before and after the SOTA study. The SOTA study. Yeah, there's estrogen levels before and after. We did not measure estrogen levels. I was just thinking about it. You talking about a protective effect of estrogen could happen, and that's also. So.
Piggyback on that.
Sure.
Did they all start at the same point of menstrual cycle? I think is what Amadeus asked.
Yeah, so we did not control for menstrual cycle. And so one of the challenges of doing that study is they would be drinking the soda for 10 days. And so scheduling them for their pre and post test visit and then trying to control for a menstrual cycle, it wasn't the most feasible. Oh, the study is amazing. I mean, study is actually so hard, but just curious, yeah. That was great. Yeah.
Just to double down on that, nice talk, by the way, but did you record at what point in the cycle they were in? Like, hey, this is your standard cycle, you're on day 6 when you started?
We did not. So, I talked about the role that estrogen, the protective role of estrogen in the vasculature. However, there's some recent reviews and recent data that how much protection we think estrogen is providing on the vasculature might not be as much as we previously thought it is. And so there's an argument whether you should control for menstrual cycle or not, and they argue for both sides of it. But we did not control or record where they were at in their menstrual cycle for that study. Yeah.
Great talk, James. I'm just curious, just again with the SOTA study, did you guys do like individual food logs before got into the study? Just because I'm curious, what kind of effect would it be if an individual came in, let's say, and had a more like nutrient dense diet, rich in like polyphenols, things like that, like the vasculature, and then suddenly change their diet into this, like what you said, 2 liters.
Yeah. Yeah. Yeah, it's a good question. We did not take any sort of dietary records from these individuals. There was, as part of the screening process, we asked them what does a normal diet look like for them, but we did not get like a dietary record like 3 days prior to them starting the study, for example. Yeah. Yeah, Mark.
Keep harping on the SOTA study. That was really popular. Nice job, James. I am curious if subjects were prompted like drink soda throughout the day versus like you just need to get 2 liters in. If I'm imagining that some of these participants are just like, I'm just get my big gulp out, get done in the morning.
So I checked in with all the subjects every day, just asking how are things going. There was no rules in terms of you need to have 3 of your 6 cans done by this arbitrary time. What I found from people, their feedback was the people that waited until a few hours before they go to bed and they had 3 or 4 cans of soda to go. That was quite hard. They didn't like that. So I learned early on to start encouraging people to kind of start drinking their soda early in the day as possible and try to have a can maybe every 2 or 3 hours, because the ones that started drinking soda kind of closer to bedtime and the majority of their soda, they might have found that upset stomach, it affected their sleep, things like that. But we did not have any rules that the soda needs to be completed at this, just drink your 6 cans within the 24 hours.
Do you expect to see any sort of differences based off people that are having this style when they drink all of this early on versus throughout the day, given that I don't know if it's necessarily been tested with the vasculature, but insulin sensitivity changes throughout the day. Big bolus versus
I do think there would be differences there, but I think there's also a lot of other factors at play. So for example, right, if I was to participate in that study and I decide to drink all 6 cans of soda at 9 a.m. and then throughout the rest of the day, right, I'm eating my meals and all of that, or maybe I'm just kind of feeling full and not eating much afterwards, that can also impact the vasculature compared to individuals, let's say, and what I encouraged is have a can of soda every 2 or 3 hours. I recommended for them to have a snack every time that they had a can of soda. And I think, as a researcher perspective, depending on when you're assessing like flow media dilation, for example, that can impact how much soda and how quickly after they consume their soda are you measuring these things. And so what I recommended for them when they reached day 10 was to have all their soda completed, and because some of the soda had caffeine in it, to have all that completed at least 12 hours prior to our vascular measurements.
I have one more question, Gavin. Oh, we got two more. All right.
And it's an energy balance question. So 10 days, it's 1,400 calories extra per day. Is that correct?
So we recommended for them to maintain their current dietary habits, and the soda was about 1,400 extra calories a day. Now, in terms of whether they were maintaining the diet or they were feeling kind of full from the soda, I can't speak on that. We didn't do any dietary records, but we told them to keep eating the same throughout. Just add on 6 cans of soda a day.
The last comment is if they had maintained their regular intake, that's an extra 14,000 calories. You divide by 3,500 calories per pound of fat, right? They didn't gain 4 pounds of fat, did they? They gained a little bit of fat.
Yep.
Yeah. So they were efficiently probably getting rid of some of these calories because they were young. And I'm interested in whether or not you could calculate that, don't have to answer, and whether women are different than men in terms of fidgeting, in terms of inefficiency of excess calorie intake.
Question. Yeah. Good points.
Gavin, you want to add?
Yeah, I'll ask him real quick. Great job, James.
Thank you.
So I noticed in the diet, you combined men and women weight loss data. Did both males and females lose weight?
This one. So they, men and women, in terms of the body weight percentage loss, they both lost weight. Yes.
They both lose calories.
Yes.
Thank you.
That soda or water?
No, this is the big.
This is water. Always water.
Thank